everyone, my name is Vicky Hoy, and I'm here to cause a cure because I finished treatment last month and understand perfectly the troublesome journey that osteosarcoma patients are subject to. I hope our conference and research can help improve the lives of fellow osteosarcoma warriors and the treatments they endure. I am pleased to introduce Dr. Mascarenas, who will be moderating the Improving Existing Therapies panel. Dr. Mascarenas is the Deputy Director of the Cancer and Blood Disease Institute and Section Head of Oncology within the Division of Hematology and Oncology at Children's Hospital of Los Angeles. He is also the Director of the Sarcoma and Solid Tumor Program, the Director of the Early Phase Clinical Trials Program, and the Principal Investigator for the Children's Oncology Group at CHLA. He serves as the chairman of the voting body of COG and a member of the Bone Sarcoma and Soft Tissue Sarcoma steering committees. He's an associate professor of pediatrics at the Keck School of Medicine at University of Southern California. Dr. Mascarenas is an internationally recognized expert in pediatric sarcomas and solid tumors. His research focus is on clinical trials for sarcomas in pediatrics, adolescents, and young adults, as well as developmental therapeutics for pediatric solid tumors. Thank you.
Thank you, Vicky. And thank you to Christina and the organizing committee for inviting me to chair this panel discussion today. We have an incredible lineup of speakers and topics, and this is a more practical session. It's a humbling experience to be here in the midst of so many osteo warriors and their families. And looking up, I recognize many of the osteo angels, and so anything we can actually do to improve outcomes for our patients is fantastic. And I want to congratulate MIB for really moving this forward. It's real. You're making a real meaningful difference, not just for patients and families, but also for moving the field ahead scientifically. So thank you. With that, I have the pleasure of introducing our panelists. First up, we are going to have Dr. Stacy Zahler, who is a clinical assistant professor in the Department of Pediatric Hematology and Oncology and Bone Marrow Transplantation at Cleveland Clinic Children's. She trained at Maria Ferreri Children's Hospital in Westchester, New York, and her current research interest is in the epigenomic differences between pre- and post-treatment in rhabdomyosarcoma, and she has educational roles as the Associate Director of the Medical Student Clerkship at Case Western Reserve University and Cleveland Clinic Lerner College of Medicine, and the incoming Program Director of the Pediatric Hematology Oncology Fellowship Programs. Congratulations, Stacy. And she will be talking to us about maximizing safety, efficacy, and tolerability, the use of liposomal doxorubicin in children, adolescents, and young adults with advanced sarcoma. Our next speaker is Dr. Katie Janeway. I don't think she needs an introduction to this audience, but Katie is, as you know, a member of the board of directors here, and she's the director of clinical genomics at the Dana-Farber Cancer Institute, and also the chair of the Bone Sarcoma Committee of the Children's Oncology Group. Dr. Janeway's prior work has uncovered genomic events underlying difficult-to-treat childhood solid malignancies. She has leveraged this understanding to expand treatment opportunities and improve clinical trials for children with advanced childhood solid malignancies. Her research group is currently focused on better characterizing the clinical impact of genomic sequencing. A major project in the laboratory addressing this question is the ICAT2 GAIN Consortium study, which has enrolled and sequenced over 500 patients with difficult-to-treat childhood solid cancers, and the interim results were just published a couple of days ago in Nature Medicine. Congratulations, Katie, on that fantastic work, and I still haven't read the paper completely, but I will do it by the end of this week. Her group is also involved with efforts to share and aggregate both sequencing and clinical data to enable a deeper understanding of childhood cancers. They have several data generation and sharing projects aimed to better characterize the genomics of osteosarcoma and Ewing sarcoma. With these projects, they hope to identify clinicogenomic factors explaining prognosis and treatment response as well as resistance. Next, we have Dr. Scott Sauer, who is the head of preclinical discovery at Vujade Sciences, and I'm going to say that again, it's Vujade. All right, Dr. Sauer is a passionate and innovative scientist with extensive expertise and a dedication to making it better for all osteosarcoma patients. Scott's multidisciplinary training in the fields of cancer biology, immunotherapy, and organic chemistry provides a unique perspective to tackle difficult biological problems and unmet medical needs, such as preventing osteosarcoma recurrence, the primary focus of his work at Vujade. Dr. Sauer received his postdoctoral training at Duke University, primarily in cancer biology, focusing on mechanisms of therapeutic resistance and disease progression. During this time, Scott received numerous postdoctoral awards, including his work on the interplay between cancer progression and environmental toxicants. Scott received his PhD at Duke University in organic chemistry and a BS from the University of Maryland in 2005. And finally, we have Dr. Emily Pope, who is a graduate student in veterinary medicine and a PhD candidate at the University of Minnesota. Emily is interested in identifying the underlying drivers of chemotherapy resistance in metastatic osteosarcoma to improve patient outcomes in human and veterinary medicine. In particular, she's focused on understanding the role of hyaluronan plays in preventing effective chemotherapy treatment in osteosarcoma lung metastases. Her PhD research also focuses on identifying novel genetic drivers of human cancers using Sleeping Beauty insertional mutagenesis screens. She has received multiple grants for her research and has been awarded several national scholarships and fellowships, including the Dr. Jack Walter Leadership Award, the Al Weber Veterinary Medicine PhD Fellowship, and the Zertis Veterinary Student Scholarship. And without much further ado, I'd like to invite Dr. Zela to start off with the first presentation, Maximizing Safety, Efficacy, and Tolerability, the use of liposomal doxorubicin in children, adolescents, and young adults with advanced sarcoma.
Thank you, Leo, and good afternoon, everyone. It is an absolute honor to be here, and I want to thank the MIB and Factor family for inviting me here to talk to you today. Next slide, please. Is it showing? Oh, there we go. Okay. Oh, I have to advance.
Yeah.
Thank you. I forgot. Okay. Perfect. So today we're going to be discussing the use in our single institution of liposomal doxorubicin in our patients, in our children, adolescents, and young adults with advanced sarcoma. Take me a second to get used to this thing. I have no disclosures. As we all know, pediatric sarcomas can be extremely stubborn, especially in the relapsed setting and then in the refractory setting. And the typical conventional chemotherapy regimens that we have today, such as MAP, can be just grueling. And our patients are admitted to the hospital for the intensive chemotherapy that they're given, and they may require extended hospitalization or have to come back to the hospital for the side effects of that chemotherapy that we give, and that can lead to battle fatigue. And with battle fatigue comes the decreased ability to tolerate further treatment. And so conventional doxorubicin has been used in osteosarcoma for decades and decades. It's part of our first-line MAP regimen that we use. And the pegylated form, which is pegylated like liposomal doxorubicin, was FDA approved many years ago in 1995 for Kaposi sarcoma in HIV-positive patients. for ovarian cancer and for multiple myeloma. And since then, it has been studied and used in other sarcomas as well, and there's an off-label use for that in the relapsed refractory setting. The way that liposomal doxorubicin works is there is a polyethylene glycol outer layer, or PEG, that's where PEG comes from, and inside that is a lipid bilayer, or liposome, and that entraps the doxorubicin sulfate in the center, and it allows it to remain in the circulation for longer. The half-life of pegylated liposomal doxorubicin is about 55 hours, depending on the dose that you give. And so that the thought is that it increases tumor exposure, and it also has been shown to decrease toxicities. Patients who receive liposomal doxorubicin do not lose their hair, typically. They have decreased cardiotoxicity, and this has been shown in adults. And the cytopenias is also less. And this drug has been studied in the pediatric population some, and there have been a few reports in the literature, including our own Dr. Trucco and colleagues with the phase 2 study of temsirolimus, but there haven't been any randomized trials with this drug in osteosarcoma, let alone any sarcoma. So what I just want to do today is to share our experience with the use of liposomal doxorubicin in our single institution in pediatric and young adult patients with advanced sarcoma, and to explore the tolerability and efficacy of this drug in this patient population. So what we did was we did a retrospective review of 45 patients within a 5-year time span. And these patients received liposomal doxorubicin for relapsed or progressive disease at anywhere between 20 and 50 milligrams per meter squared per dose, IV monthly. And when appropriate, the drug was combined with other agents, and I will show you that. And we did some descriptive analyses. So this is a bar graph to show you that there were many different types of sarcoma that were in our group of patients, but the majority of patients did have osteosarcoma. 16 out of 45 did. There were also other sarcomas such as rhabdomyosarcoma, Ewing sarcoma, and then the other non-rhabdo soft tissue sarcomas that you see here. And you can see in this table here that the median age at diagnosis was 16. The median age at the time of liposomal doxo treatment was 19. And this is just a pie graph to show the location of primary tumor site at diagnosis, the most common being the femur or thigh, in 22%, with others there, as you see. Prior to treatment, it might be a little difficult to see, but these patients, as I mentioned, had progressed or relapsed, or sometimes both, prior to receiving this agent. And you can see here that the majority of patients received liposomal doxorubicin on their first progression or relapse. The majority also had metastatic sites of disease at the time of treatment, and there were 16% of patients that had a local relapse at the time of treatment. The chart on the right does show that the median number of prior chemotherapy regimens for these patients was 3, but ranged from 1 to 7. And the prior radiation received was about 80% of patients had received prior radiation, and the cumulative radiation dose received was 55 gray median, though ranged from 30 to 211 gray. So some patients had received multiple courses of radiation therapy. And this table shows the first set shows that these were the agents that liposomal doxo was combined with. 41% of patients had vincristine or temsirolimus, or the combination. There was one patient who had received pazopanib, a few patients that received high-dose methotrexate, sort of alternating with liposomal doxorubicin. And I put radium here because there was one patient who had received 2 cycles of liposomal doxo prior to the radium, but not concurrently with. So we didn't count that patient. The progression here, so 11% of patients, well, the total, so this is a little bit confusing the way it's worded, but the patients that did progress on therapy were 32 patients, so about 71%. And the median number of cycles before progression was 2, with a range of 1 to 22. And the next shows that if they did not progress on liposomal doxo, then the time to progression was 12 months, and the range was 2 to 27 months there. There were patients that did not progress, though, and I'll show you that. There were minimal toxicities with this drug. So we had only 11% of patients who had to stop the drug due to toxicity, and there were no secondary malignancies. And interestingly, we were able to give concurrent radiation with this drug, and we don't think of conventional doxorubicin as an agent that we are able to give concurrent radiation therapy with because of the risk of radiation recall. But with liposomal doxorubicin, we were able to give concurrent radiation therapy in 22% of patients. And the majority of the type of radiation therapy was stereotactic body radiation therapy, or SBRT. And these are just the sites that were radiated during liposomal doxorubicin. There were several, but the majority was in the lungs. And here is a bar graph that shows the cytopenias that occurred. And while there were cytopenias of all the cell lines, which is the first bar in each of the categories, the middle bar on each of the categories is grade 3 or 4 toxicities, or a grade 3 or 4 suppression. And so that was significantly lower. And then the third bar in each of the categories there is whether or not there was a need for a blood or platelet transfusion. And the orange is whether or not there was febrile neutropenia. And so there were only 3 patients that had an episode of febrile neutropenia out of the 45. This is just to show you that 80% of patients were able to remain out of the hospital during liposomal doxorubicin. And the ones that did require hospitalization, these were the reasons for hospitalization, the most common of which was fever with or without neutropenia. These are the survival curves, and the left shows the progression-free survival. And clearly here we know we need to do better, and we've been talking about this all weekend, the need for better agents, targeted agents, perhaps targeted agents in combination with liposomal doxorubicin. But the overall survival, interestingly, was 52% at 4 years. So in summary, just wanted to really relay that multiply relapsed refractory sarcomas can be treated effectively with liposomal doxorubicin, that this drug is an appropriate option for our pediatric and AYA patients, and importantly, with minimal toxicity and an improved and optimized quality of life, and that this drug can be given concurrently with radiation, specifically with SBRT. I want to thank our group at Cleveland Clinic Children's. I want to thank MIB, and I also, most importantly, want to thank our patients and families. Thank you very much.
We'll save questions till the end. Next up, we have Dr. Janeway, who will be speaking to us on glucophadase use in 86 pediatric and young adult patients receiving high-dose methotrexate therapy, pooled subgroup analysis of open-label trials.
Good afternoon, everybody. It's delightful to finally be here. I'm sorry to have missed the last 2 days, and I've enjoyed seeing people tweeting and emailing about how great the presentations have been. These are my disclosures. Here's the background for this presentation. So high-dose methotrexate is used to treat a range of cancers, and I think everyone in this room probably knows, including osteosarcoma. In spite of the supportive care we provide, delayed methotrexate elimination or toxic methotrexate, which is a very high level of methotrexate after administration, can occur with high-dose methotrexate treatment. And that high level can be associated with acute renal injury, which then further kind of enhances or delays methotrexate excretion. And that situation can lead to downstream effects on organs such as the liver and also on blood counts. The effectiveness of glucarpidase, which I'll tell you about on the next slide, was studied for rapidly reducing methotrexate concentrations in this situation where the methotrexate is high or slowly being eliminated, and the kidney function is effective. And so the objective of this presentation is to characterize the glucarpidase efficacy and safety in pediatric and young adult patients with delayed methotrexate elimination after high-dose methotrexate therapy in these compassionate use trials. So glucarpidase converts methotrexate into two non-cytotoxic metabolites, DAMPA and glutamate, that are eliminated primarily by the liver and not the kidneys, and thereby rapidly lowers methotrexate plasma concentrations. And I should mention that glucarpidase or Varaxase is FDA approved. Importantly, the immunoassay methods that are usually used to measure methotrexate in the laboratory don't distinguish between methotrexate and DAMPA. And so after the administration of glucarpidase, HPLC, which is a high-performance liquid chromatography, is more accurate and specific for methotrexate than these methods of measurement. So this study design of this analysis, it's a pooled post hoc, meaning we decided to do this after these compassionate access studies were completed. Analysis of data from these multi-center, open-label, single-arm glucarpidase compassionate use trials. To be included in these trials, patients had to have delayed methotrexate elimination secondary to renal dysfunction, which is defined as methotrexate concentrations greater than 2 standard deviations over the typical methotrexate elimination curve, greater than 12 hours following high-dose methotrexate administration, or what the number that's relevant to osteosarcoma patients here, greater than 50 micromoles per liter, and then serum creatinine levels that are 1.5 times the upper limit of normal. And so in this, if patients had those criteria and were enrolled in these studies, they would receive intravenous glucarpidase at an initial recommended dose of 50 units per kilogram, and subsequent doses were permitted if methotrexate levels remained elevated or delayed. And plasma sampling for methotrexate was performed with an HPLC analysis before and less than or equal to 8 days post-glucarpidase treatment. The primary endpoint was the proportion of patients who achieve a rapid and sustained CIR in plasma methotrexate, which is defined, CIR is defined as a methotrexate concentration less than or equal to 1 micromole per liter at all measurements after the first dose of glucarpidase. The secondary endpoint is the % change in baseline methotrexate concentration and recovery of renal function and safety of glucarpidase. And data were analyzed by age group, infants, children, adolescents, and young adults. From here on out, I will not talk about the infants because that is not relevant in osteosarcoma. So here, this table shows the patient characteristics, and the key points here are that overall 55% of patients had osteosarcoma, and most patients received 1 or 2 doses of glucarpidase. This figure shows the methotrexate concentration over time by age group, and what you can see is that the median reduction in methotrexate level was greater than or equal to 98.7% in each age group, starting 15 minutes after glucarpidase was administered. So very effective reduction in methotrexate concentration. This bar graph shows the primary endpoint of CIR, which, as a reminder, is methotrexate level less than or equal to 1 micromole per liter. And I'm showing this in a couple different ways. In the green are by diagnosis. In the blue is by age group, and in the purplish pink colors is by methotrexate concentration. And so what you can see here is that the osteosarcoma patients actually, a smaller proportion of the osteosarcoma patients have that CIR endpoint, which is, again, less than or equal to 1 micromolar. And that's because most of the osteosarcoma patients will receive glucarpidase when they have a level over 50 micromole at the time soon after their 24-hour methotrexate level. And so what you can see in the pink is that if your level is greater than or equal to 50 micromole, only 2% achieve that CIR, which is less than 1 micromole per liter. But remember, the key slide actually for the osteosarcoma patients is the slide I showed you before, which is that 99% of patients have this dramatic reduction in methotrexate level. And that reduction in methotrexate level is probably sufficient to protect the kidneys and also the organs and prevent significant count suppression. That's just animating what I just told you. Another secondary endpoint of this post hoc analysis was serum creatinine by time and age group. And I will just summarize this figure by saying that reductions from baseline in serum creatinine concentration were demonstrated, which indicates sort of recovery of renal function in these patients. This table shows the most common treatment-related adverse events, which was paresthesia, which is a known side effect of this medication, and no other treatment-related adverse events or grade 3 or 4 adverse events occurred in greater than or equal to 5% of patients in any age group. So in conclusion, after accounting for baseline methotrexate, the efficacy of glucarpidase at inducing a CIR and plasma methotrexate concentration in pediatric, adolescent, and young adult patients with methotrexate levels less than 50 micromole was in line with that was previously reported in the overall patient population, which is what the FDA approval is based on. The median percent reduction in methotrexate concentration was greater than 95% at the first post-glucarpidase measurement across all of the age groups looked at and all of the diagnoses. There were no unexpected safety findings in the younger patients. And so in summary, these findings suggest that glucarpidase, 50 units per kilogram, is an effective and well-tolerated dose for pediatric, adolescent, and young adult patients, and no dose adjustment is required for younger patients receiving this drug. This study was supported by Protherix Medicines Development Ltd. There was medical writing support provided, and I think that is my last slide, in spite of there being another slide. That one is just if people ask questions. So thank you very much for your attention.
Thank you. Thank you, Katie. Next up, we have Dr. Sauer, who will speak to us about the title of his talk is Toward Rapid Development of a Cure for Osteosarcoma Using a Two-Drug Combination of Repurposed Drugs Directly to Phase 2 with Potential Accelerated FDA Approval.
Thank you for reading that mouthful, and thank you to MIB for putting this conference back together in person. I could say for myself and a lot of people that we really missed this. And really thank you for providing me the opportunity to update everybody on the progress we made at Vujade over the last year. For those of you who aren't familiar with us, we're a biotechnology company based out of Boston that is specifically dedicated towards preventing metastatic recurrence, specifically in osteosarcoma. And to do so, we target microscopic dormant disseminated tumor cells, or DTCs, which we feel act like ticking time bombs in distant sites, laying in wait and eventually leading to the main cause of mortality in OS, recurrence. So this is a fairly wordy slide, and most of you are familiar with a lot of this, but it's a timeline of osteosarcoma treatment over the last 100 plus years. And I'm going to skip over the whole first 2/3 of it just to say that for about 80 years, we've finally converged on the current standard of care, which is surgery as well as MAP chemotherapy. And that has led to much better outcomes from 17% to 60% 2-year progression-free survival. However, since then, there have been no approved therapeutics for osteosarcoma. While we have seen some modest activity in recent clinical trials with multi-tyrosine kinase inhibitors, they still have not yet made it to full approval. However, if we look even just a little bit into the horizon, we feel that there are 2 potential game changers that could really help us address metastatic recurrence. And that is drugs that can target a phenomenon that we've dubbed metastatic endurance, which I'll get into a little bit later, as well as immunotherapy. And while there have been maybe less exciting results with checkpoint inhibitors, we think that the cell therapy aspect of immunotherapy holds a lot of promise, in particular NK cells, as you guys have heard earlier today. So the problem with disseminated tumor cells is that they possess this unique feature called metastatic endurance. And it encompasses a whole variety of features, including the ability to adapt to stress, the ability to stay dormant, and the ability to survive even in spite of aggressive treatment. And much like a marathon runner, it's this metastatic endurance that enables these cells to continue on even during inhospitable migration to the lungs and treatment options, only to emerge months or years later in a recurrence. However, just like a marathon runner, we feel like if we can take the wind or the metastatic endurance out of these DTCs, we can actually prevent recurrence from ever happening. And if we can do that, the cancer will lose. In order to do so, we've put together what we feel is a really unique and powerful workflow to identify these types of therapies. The first aspect of this is drug candidates. We at Vujade are very pragmatic. We just want to find whatever will help patients, whether that be repurposed in preclinical small molecule drugs, biologics, or cell therapies. However, for our first product, we're exclusively focusing on repurposed drugs because we feel this provides the quickest opportunity to get something to the clinic and help patients. So in order to find these drugs, we have a few unique assay systems that we think really reflect the metastatic environment. In particular, we have multiple in vitro 3D systems that mimic the 3D conditions of DTCs, particularly in the lungs. And it's made up of extracellular matrix that provides an architecture similar to what these DTCs would experience once they land in a secondary site. Further, we can tweak the conditions a little bit to impose metastatic endurance, wherein these cells actually stay dormant for a period of 3 to 4 days before reaching a period of rapid growth, very similar to the clinical time course on a much, much smaller time frame. This has allowed us to screen over the last year and a half or so 3,000 clinical stage drugs. And from this, we've identified 7 priority drug classes. And we were able to validate these classes by identifying those drugs that are from the same class that all show activity against metastatic endurance. And further, by testing these across a variety of specifically highly metastatic osteosarcoma cell lines. This allows us to feel a little more confident that whatever it is they're targeting is not an artifact of any one cell line. Further, I think this crowd is very well poised to understand that combination therapies are really what's going to make a difference. And so once we've identified these classes, we've started testing all the various permutations of combinations to see what's going to give us the best efficacy. Once these optimal combinations have been found, we can progress them into an even more translational assay called PUMA. Some of you may be familiar with this technique that was developed by Chan Khanna, but for those who aren't, briefly, you just inject fluorescently labeled cells into the tails of mice. These cells traffic to the lungs super quick, 15 to 30 minutes, and we can take out the lungs, section them, and this allows us to treat with multiple conditions, multiple doses on a single mouse over a much shorter time frame than longer-term in vivo studies. And the beauty of this assay is that it's already been biologically validated to correlate with these longer-term spontaneous and experimental metastases models, but in a more higher throughput and cost-effective way. And gratifyingly, we've seen that every class that has shown activity in our initial in vitro screen was confirmed once we tested it in PUMA. And further, this extends to our combinations as well. We've seen very similar trends. So if it's active in our in vitro system, it's been active in our ex vivo system, giving us further support that we're going down the right path. Now that we've kind of validated some of these combinations, we need to nominate our actual development candidate. And to do so, we've used our proprietary data platform, ME Select, which helps us identify which of these agents and combinations are not only highly active against metastatic endurance, but also highly selective. This means that they're much more active in these systems than they would be if you just treated rapidly dividing cells growing in a dish. Beyond this, we also take into account business considerations that will allow us to more rapidly translate these drugs to the clinic. So are these drugs on or off patent? Can we move them forward aggressively? And I'm happy to report that we've now landed on a lead program that we've dubbed VUJ100. And it's a combination therapy that includes 2 small molecule inhibitors with well-established targets, as well as a wealth of clinical data, both PK and safety. I'm not at liberty to discuss the specific drugs or targets at this time, but because these are both repurposed agents, there is accelerated development potential to push these into phase 2 without us having to replicate some of the pharmacokinetic and safety data. In addition to that, this product has a very low dose profile where each of the drugs, when combined, are used at much lower doses than what was used originally in the clinic, thus providing us a much larger therapeutic window of both safety and tolerability. Further, by using a drug combination, we hope that we can inhibit drug resistance to any one pathway, as well as enhancing the activity, reducing the drug exposure. And then a little bit later, I'm also going to share some details about an exciting collaboration that we have with our neighbors just down the street in Boston at Cell, developing an NK cell therapy for osteosarcoma along with our ME targeting drugs. So just backtracking a little bit, I want to describe at a very high level VUJ100, which is really just 2 drugs, VUJ001 and VUJ002. And as you can see here, they both target generic network number 1 and generic network number 2. But all you need to know is that these are independent networks that may have some functional overlap, but predominantly have non-overlapping functions. And we feel that this is a really good approach to target metastatic endurance because we can block things like proliferation, drug resistance, the ability of these cells to evade apoptosis and survive, as well as a whole host of other functions that are both shared and non-overlapping between these 2 networks. And by doing this, we really hope that this provides us the best chance to truly make a dent in this disease. So circling back just really quickly to our partners at Cell, we're very excited that we announced this about 2 or 3 months ago, that in parallel to us developing our combination approach, we're also working with Cell to leverage their proprietary iPS-derived off-the-shelf NK cell therapy to prevent recurrence specifically. One limitation of NK cell therapies is that they don't work great in large solid tumors. However, we feel they may be uniquely poised to prevent recurrence at the single cell or very small cell cluster because there's less of a physical barrier for them to exert their action, as well as the fact that they've had less time to remodel the architecture into an immunosuppressive environment. Thus, we feel that combining the expertise of our company and our anti-metastatic platform with their off-the-shelf NK cell therapy, we can really, truly have a good chance at making it better. And then lastly, I'm going to say that we're well positioned for success too by pulling together a world-class team of both drug development experts as well as experts in the field of osteosarcoma, and 2 names that I'm sure everyone here is familiar with, John Khanna and Lee Hellman. And it's truly the confluence of this expert team, our exciting scientists, and the support of this amazing osteosarcoma community that we really think we can see victory in sight. Thank you.
Last but not least, I'd like to invite Emily Pope to speak to us about evaluating the role of hyaluronan in osteosarcoma pulmonary metastases.
Thank you, and thank you to the organizers for the opportunity to speak here today about some very early stage work that we're doing looking at the role of hyaluronan and how it contributes to chemotherapy resistance. To give a little bit of background, hyaluronan, or HA as I'll call it for the rest of this talk, has a lot of roles in normal biology that I won't have time to go into, but the basics are that it's a very simple non-sulfated glycosaminoglycan molecule, and it's extremely hydrophilic. So if you use skincare products to prevent wrinkles, it's in there. It's the main ingredient. And an important thing, please. Thank you. It's highly abundant. So the average human has about 15 grams of HA in the body, and a third of that completely turns over every single day. We were interested in HA in particular because it's known to play multiple roles in bone that we thought might make it important for osteosarcoma. So it's known that small HA fragments can induce osteoclastic bone resorption, and that conversely, if you inhibit that resorption, you'll increase the amount of HA. It's also been demonstrated to increase osteogenic gene expression by playing a role in the TGF-beta and SMAD signaling, and it plays a role in pre-osteoblast recruitment, proliferation, and differentiation, which obviously for osteosarcoma is really important. Now, I want to note that this is not a new idea, and in fact, hyaluronid's role in osteosarcoma has been explored before. In the early 2000s, there was a study out of the DeLange-Davies group where they looked at whether hyaluronin was physically preventing the uptake of chemotherapy. So what they did here was they had flank tumors in mice, and they injected hyaluronidase directly into the tumor and then measured how far doxorubicin was able to penetrate into the tumor. So in the top image there, you have a mouse that just got doxorubicin, and you can see that that green fluorescence is really limited to the tumor periphery. Whereas in the bottom image, for a mouse that got hyaluronidase, you see a much more robust signal coming from the tumor. And this work was really exciting, but there were a few shortcomings that made this kind of a jumping off point for us, and there's a reason that it kind of stagnated after 2005 that I'll tell you on the next slide. But one of the things that we noted with this study was that, intratumoral administration of hyaluronidase is simply impractical for patients with metastases. You're not going to do a thoracotomy and inject hyaluronidase. And part of the reason that this never took off is because the half-life of hyaluronidase in the circulation was just not going to be feasible for use in the clinic. It had a half-life of about 6 minutes. So we started working with this company, Halozyme, and they pegylated, and you just heard about pegylation from Dr. Zoller. They pegylated hyaluronidase, and that increased the half-life to about 17 hours, which made it much more viable. And I just want to explain a little bit how this works and why it works in tumors. So when you have a tumor that has a lot of HA in it, it increases the interstitial fluid pressure, and that ends up compressing your vasculature. So you're delivering chemotherapy through those blood vessels, but they're being crushed, so you're not getting into the tumor body. Whereas when you break down the HA, that allows for better vascular perfusion, and you can deliver your chemotherapy much more effectively. This has been shown in soft tissue tumors like pancreatic cancer. So this work is out of Paulo Provenzano's lab at the University of Minnesota. So in this leftmost panel, we have a normal pancreas, and you can see doxorubicin fluorescence throughout it. But in the middle panel, which is a pancreatic tumor that was just treated with doxorubicin, you only see a few little pinpoints of green, and you can barely see vessels in red at all because the pressure is so great. But when they added this PEG-PH20 drug, you can see that there's this huge surge in doxorubicin fluorescence, and in fact, you can see vessels that are loaded with dox as well, represented by the yellow with the asterisks. So that's all well and good, but we first had to answer the question of if this was even relevant in both the bone microenvironment and the lung microenvironment for osteosarcoma. So we started out by looking at samples from human patients, and we just looked for HA to determine whether they were HA rich. And you can see from all the samples that we looked at that they're staining very strongly positively for HA. And when we zoom in on it, we see that there's these pericellular coats of HA, and none of it's in the nucleus. We then moved on to looking at it in the lungs and found that lung metastases of all sizes appear to produce HA. So on the left, that's a grossly visible macrometastasis in the lung, and then the smaller one is about 50 micrometers in size, and it too is producing HA. We originally had hypothesized that it might be a defensive response to chemo, but neither of the mice pictured here got any chemotherapy, so that part of our hypothesis has been proven not to be true. We then wanted to make sure that it was actually coming from osteosarcoma cells and not from stromal cells, because if we want to target it, obviously we want to target the cells that are the main problem. And we found that osteocells that are highly metastatic produce HA amounts similar to that of osteoblasts, which we knew would produce a lot of HA. But poorly metastatic osteosarcoma, shown by that blue bar, the U2OS cells, produce much, much reduced levels. We also looked at whether chemotherapy could affect the amount of HA that was put out, and we found that it decreases it, but it does not eliminate it, and you do see a rebound effect over time. So the main part of this study that I want to tell you about today is we looked at PEG-PH20's effect at 2 different time points. So we first wanted to make sure that it was going to have any effect in the lungs at all. So we gave PEG-PH20 and doxorubicin and then sacrificed the mice 48 hours later. And then we looked to see if it worked in combination with a full course of MAP. So we'll just refer to those as experiment 1 and experiment 2 going down the line. And the first thing that we found is it does indeed ablate HA very effectively in lung metastases. So this top panel is from that first experiment, where this is 48 hours later. And the second one is from the second experiment. And I just want to highlight it because while you do see some resurgence of HA in the bottom one and that MAP plus PEG-PH20, This is also 8 days after their last dose of PEG-PH20, so the effect lasts a lot longer than the drug is in the system, and we were pretty excited about that. We next looked at whether actively dividing cells were affected by this, and we found the same thing, that in both groups that received PEG-PH20, there was a statistically significant difference in the number of cells that stained positive for Ki-67. And then finally, and the most important thing that we found from this study, and kind of a surprising result to us, was that when we targeted HA, we significantly reduced the metastatic burden in the lungs. So this is data only from the second experiment. These are mice that received 1 round of MAP therapy plus or minus PEG-PH20. And we had noticed on necropsy that there were significantly fewer macrometastases, to the point that it was really, really noticeable when we were doing it, and we thought that was pretty exciting. And then on histopath, we confirmed that there were fewer micrometastases too. And I just want to hammer this home because that difference is really, really stark. I mean, that's half the number of metastases that we saw in the mice that got MAP therapy alone, and we really did not expect to see that drastic of an effect with only a single round of MAP. So we're pretty excited moving forward. So just the conclusions from this. We know that osteocells can produce their own HA even under stressful conditions. We know that primary and metastatic tumors are HA enriched, and that this tumor-associated HA can be targeted with systemic administration of PEG-PH20. We gave it intraperitoneally in our mice, but you can also deliver it IV. We know that targeting HA in combination with chemotherapy decreases the amount of actively dividing cells within lung metastases compared to mice that were treated with chemotherapy alone, with the caveat that this was looking at only a single time point, and we don't know at this point what it would be over time. And then most importantly, targeting HA in combination with MAP therapy appears to substantially decrease the metastatic tumor burden compared to MAP therapy alone. As you can imagine, there are a lot of future directions for this work. This was a very early pilot study. So some of the in vitro work that we're going to be doing in the future is looking at the hyaluronan synthase genes, or HOS genes, and characterizing their activity in response to chemotherapy and other stressful conditions. We'll look at other genetic changes that might occur when we break down HA and if we blockade its formation, because you can do that with 4-methylumbelliferone. And then clearly we'll look at chemosensitivity when we target HA, and then if we block its further production. And then in the mouse work, we have a lot of mouse work that we can do with this project. All of the results that I showed you here were in immunodeficient mice, but we have a fully immunocompetent Sleeping Beauty accelerated mouse model that we'll be using to look at how breaking down HA might affect immune cell infiltration, might affect immune gene signature activity, and then we can use the Sleeping Beauty system to identify other driver genes that might be playing a role. We also need to do a longitudinal survival study with this chemotherapy regimen and with PEG-PH20 added to it to see if the effect that we noticed after a single round persists over time. But we're very, very hopeful for this drug and for the future. And then we're hoping that within the next couple of years that maybe we can test this in dogs. So this has been safety tested in dogs before, and they tolerate it very, very well. Mice also tolerate it well. And so we're hopeful that once we do our longitudinal studies and make sure that there's still a benefit over time, that maybe we can look into moving this into the clinic. And with that, I just want to thank the huge team behind this project. It is certainly not a one-woman show here. My PI, David Largaspada, has been really spearheading this project, and Paolo Provenzano has been instrumental in us working with PEG-PH20 and working with Halozyme on it. Megan Stoffield is my undergrad, who ran more ELISAs than she probably would ever like to run in her life. And with that, I'm happy to take any questions during the panel or come find me afterward, because this project has a lot going for it, I think. Thank you.
I'd like to thank all the panelists for their great and succinct talks, and this is open to questions. Go ahead.
Our first question's back here to the
Sure.
to the right.
Very nice talks, everyone. Question for Emily. For your pegylated HA, even though you've mentioned your studies were done in immune deficient mice, did you assess sort of changes to the stroma at all? Is it breaking down extracellular matrix within your tumors? Presume that's what's happening.
I'm going to get it out, I promise. Yeah, so that's a great question. And we haven't assessed that yet. We just wanted to see right now if it was breaking down HA. But the HA in the tumor stroma itself, which is why it's able to prevent your blood vessels from delivering chemotherapy effectively. So that's essentially how it works, is it breaks down this protective stroma. And we had actually originally hypothesized that HA was a defensive response, as I mentioned, and clearly that's not the case, since we had it present even in mice that didn't receive any chemotherapy. But yeah, that is how it's working, is it's breaking down that stromal component of HA.
Okay.
Did that answer your question?
Yeah. Second question is, do you anticipate any toxicities or off-target effects from
Yes,
using?
that's also a great question. The drug has historically been tolerated very well, but one of the considerations that we have and that we need to look at in the longitudinal study is that small fragments of HA have actually sometimes been shown to be pro-inflammatory, and that can actually drive a pro-tumorigenic response, right? And so that's something that I don't have an answer for right now, if that'll be a problem when we're using this long term. It's something that we're going to consider, and given that you have so much HA turnover in your body every day, we don't think it's going to be an issue, but that is one thing that we're going to be looking out for.
Dr. Healy?
Follow up on that. Have you measured the pressure within the tumor, which is your putative mechanism, or oxygen levels, for example?
Yeah, so we have all of those studies on the docket. Unfortunately, and Christina was very tolerant of my not getting my final data to her until Wednesday of this week, I think. So those studies are ongoing.
I did mine this morning.
So yeah, those are planned, and we're going to be doing them as soon as I get back.
Great.
I can follow up with a question to Emily. So your theory that because of PEG increasing the half-life of hyaluronan actually really helps. And I think of osteosarcoma as generally a chemo-resistant disease, and I think the microenvironment and stroma contribute to this resistance. And so if you can get drug into these little tumors, probably that'll be a lot better. Have you thought, are there any opportunities to have like targeted therapies delivering hyaluronan as a payload, or potentially thinking of like CAR T-cell therapies with bispecific link to potentially enzyme, payload for this tumor?
Yeah, that's a really interesting question. We had thought about it from the perspective of this could improve, cellular therapies for sure if we were breaking down HA, and then that was creating a more immune permissive environment. I hadn't thought about whether we could engineer something that would directly target HA beyond using hyaluronidase, but it's a really, really interesting thought. I don't have a great answer for it, but I'm fascinated by the idea.
I mean, I'd be curious. I think now with new drug development,
Yeah.
I mean, there's an opportunity, and you would potentially even decrease the toxicity or any other effect elsewhere.
Right, and that would
Right.
reduce the concern about having small HA fragments circulating too. Yeah,
Okay.
that's a great idea.
There's a question in the audience?
Yeah, great talk, and I have also a question for the HA stuff. So, have you thought about an inhalation method instead of injection?
We had thought about it, but we started out with doing the injection just because we wanted to see how effective that was going to be by itself. It's obviously a lot easier to do an IP injection in a mouse than to set up an inhalation system, so we figured we would give it a shot. They got a relatively low dose of PEG-PH20 compared to what's tolerated, and we actually have data that I didn't show that you could take the dose down even more. So I'm not sure that there would be a ton of benefit to doing it as an inhalation agent instead, just because, you saw we had almost complete ablation within the lung met with a single injection, but
Yeah, I'm just thinking of, like, on the top, but I remember about HA is that you can get liver toxicity.
You can, but
usually when you pegulated stuff like that, it goes to the liver.
yeah.
So it was just a thought. Great work. So interested to see what happens.
Yeah, there's another question?
Yeah, just another question for Dr. Sauer. So I think I just missed the concept of your screening platform. So in your, I don't recall if it was immune competent or immune deficient mice, where you would remove the lungs, perhaps? And what was the process after lung removal? Was that pre-drug, post-drug, or were you removing, lungs with metastases and then testing your different combination agents? Can you just clarify that?
Yeah, sure, no problem. I definitely did kind of fly past that in the essence of time, but for the PUMA studies, you basically just take the fluorescently labeled cells, they migrate to the lungs in minutes.
And these are
And
tumor
then
cells?
And then we excise them immediately. So, they don't even necessarily have a time to establish and grow out. They're all basically single cell colonies by the time we remove them. Once that occurs and we have them ex vivo, you actually put them in a 6-well dish on gel foam, and you can get maybe 40 or 50 slices per any one mouse. So even with 4 to 7 replicates per well, you can test a whole host of other things all at once. So it tends to be a lot more high throughput.
Okay, so these are live tissues that you are removing. Have you looked, I'm not overly familiar with this assay, but have you looked at cytokines and chemokines that are produced as a result of adding different drugs, just to get a sense for how you might be altering the microenvironment ex vivo?
Right, and I think that actually ties back to the other part of your question that you mentioned. These are immunocompromised mice because so far we've been specifically testing the highly metastatic human lines. So we do have the K7M2 in our lab, and we have tested those in vitro. But so far we've been working with immunocompromised mice and then doing this outside of the body, mostly because even if they were immunocompetent and even if this was a syngeneic model, by taking them out of the body, we're losing a lot of the immune system there. And so maybe there's resident macrophages, there's something in the lungs. But all of that is not to say that we're not interested in pursuing that. And I think once we get some of the model systems up and running, that's something definitely of interest.
To follow up on that, Scott, I was intrigued because the hypothesis between using repurposed drugs by Wu Jia is really to target dominant, tumor cells. And I know it may be proprietary and you're close to launching a phase 2 trial. What sort of clinical trial design are you thinking about to address this, and which will also give us insight into your hypothesis in patients?
Right, and this is definitely not my strong suit as far as the clinical design, but I do know that we're basically considering 2 options. Either resectable disease, where you would go in, resect the tumor, then we would start treating with our therapy, and we're just looking to prevent event-free survival over 4 months or something, trying to double the percentage of people that have 4-month event-free survival. But somebody else had mentioned earlier in the day another design where we're interested in potentially working on unresectable mets. And so they're unresectable, we're treating them. We don't necessarily think that we will do anything to the size of that initial met, but then we would look to make sure that we are precluding subsequent recurrence from that primary met, or that initial met. Sorry.
All right. So, Dr. Janeway, do you have any comments about that?
I have a question actually about the trial design, which is more an operational question, but I agree with you that there's a trial design that can be used, which I'll talk about a little bit later in the next session, of patients with fully resectable and resected pulmonary metastatic disease. The endpoint is a little farther out than 4 months. It's usually around 12 months. But what are you thinking about? It's more of maybe a question about how we're organized as a community. So what are your thoughts about how you might achieve a clinical trial in a rare cancer like this at the time of relapse? Like, who your partners might be and that sort of thing.
Yeah, no, that's a great question, and honestly, we are reaching out to every and all clinicians, all networks, all everything, because I showed our team, and they're an excellent team, but you didn't notice a ton of clinicians on our development side. And so we're relying on the expertise of our academic partners, as well as our other kind of scientific collaborators who have much, much more expertise on that front. And I'd be happy to talk about specific people and networks and stuff that we've already engaged, as well as just speaking more about it with you as well.
Right.
Thank you.
Thank you. And for Dr. Zahler, I guess, so pegylated doxorubicin has been around for a while, and we've used doxorubicin, as you said, for at least about 4 decades in the treatment of osteosarcoma. How do you see potentially incorporating pegylated doxorubicin in upfront therapy for newly diagnosed patients? And the big concern all of us have with anthracyclines is cardiac toxicity. And while there are some reports potentially of, cardiotoxicity not being as much with pegylated doxorubicin in patients whom we hope to cure, would that make a difference? Are there opportunities, you think, to escalate the dose, or are there opportunities to potentially decrease the dose if you have more efficacious drug?
Excellent questions, Leo. And this is exactly right. This is a drug that's just in a different form. And so to try to answer your first question, I think what we need to do is, first of all, it would be difficult, I think, to put a longer acting drug with shorter acting drugs and see less side effects. So to just replace conventional doxorubicin with liposomal doxorubicin in addition to cisplatin and methotrexate, I'm not sure that would be a great idea, because you still would have the side effects of the methotrexate and cisplatin. So really, I think it's, we obviously need to study drugs in combination in osteosarcoma. And, we've heard all about potential targets this weekend. And so, potentially, and we know that when you combine liposomal doxorubicin with temsirolimus, there can be, tolerability and some efficacy. So, using other targeted agents with liposomal doxorubicin, I think is a good idea.
Thank you. Perhaps one question for Dr. Janeway. As a clinician treating patients with high-dose methotrexate when they have really high levels, I just came off service, and 2 weeks ago I had a patient with a level of 120 at 24 hours. It makes your pulse race a little bit, and it's great to have glucosidase around. What do you think about re-challenging those patients with high-dose methotrexate, considering that glucosidase is an enzyme and protein and potentially could be eliminated with an immune response and may not be as effective? Is there any data on the efficacy of using it a second time, comparing it to the first time around?
The analysis that I showed you does not look specifically at efficacy of the second dose, although I believe that the second dose was included in that the curves that looked at the decrease in methotrexate was per glucosidase dosing, or session of dosing. My own personal experience, we have used second doses of glucosidase, but we've used them in the context of persistently low levels of methotrexate in the same high methotrexate kind of administration. The only other thing I can say from that analysis is that I think that it's safe to do. I think there were some questions, because it's a protein, about sort of immune responses of the type that cause allergy, and I think those have not been seen, is my understanding from that analysis. But I think we could look further at the data to look at those patients who received 2 doses and whether they were within the same methotrexate, kind of high-dose methotrexate course, or whether they were a separate subsequent high-dose methotrexate course, and answer your question.
All right, that's great. And but are there potentially neutralizing antibodies, you think?
I
or
don't know that I can answer
We
that
don't-
question from what I presented.
Okay.
So I think we could probably look to
Look into it.
see whether the second doses were as effective in decreasing methotrexate level, and also whether those doses were given in the same methotrexate course or a separate methotrexate course. And that would at least start to get at the answer to your question.
Great.
Yeah.
Are there any other questions from the audience?
I have a question.
Oh,
I don't
sure.
believe it this time.
Dr. Janeway has one question.
I have a question, actually. So for, I have maybe more than one question, but anyway. We have 1 minute and 56 seconds left,
Yeah.
right? Okay. For Dr. Zahler, for the doxil study, very nice study. Do you plan, I think, if I understood correctly, that the event-free survival or progression-free survival data you presented was for the overall population? Do you plan to look at the osteosarcoma patients alone?
Yes, and I should have presented that here today. That would have been very nice to show, and I certainly plan to do that, yes.
Terrific. And then this is a question for both Dr. Sauer and Dr. Pope. One thing that I'll talk about this afternoon is probably what I would call my current passion related to osteosarcoma, which is about sort of biologic subtypes of disease. And so my question for you is kind of the diversity of models used and whether you've looked at sort of the underlying genomics, epigenomics, immunogenicity of those models.
You want to go first while I'm wrangling my microphone?
Sure, no problem. So one thing about our approach is that we're almost taking a ignorant approach to targets. And so we're hoping to see phenotypic results that we can then chase down. But as far as kind of extending it into additional models, we were working primarily with the well-characterized, highly metastatic cell lines. And I think the obvious next step is to start moving into some of the patient-derived cell lines. And even some of the PDX models, if amenable to some of our platform, just to make sure. I mean, we've seen some of those clustering PCA analyses, and they do seem to have their own unique spot on that graph, and that the PDXs and PDCLs are slightly off of that spot. And so that's going to be our very next step before moving into clinical trials for sure.
My answer is going to sound a whole lot like Scott's. Not yet. So the data I presented today were essentially the result of I don't want to say a bet, but a very hot debate about whether this was going to do anything at all. And I won't say who was on what side. I'll just say I was right.
Always good to be right.
It is. It's better to be right than to be happy. But so what we're planning to do, I mentioned the Sleeping Beauty model. That's a p53 mutant that's been published before by Brandon Moriarty. So that's our next step, is to move into that, because obviously doing a single cell line injected into NRGs is, I mean, it was great for me to rub it in someone's face, but it's not enough to go off of that and move it into clinic right away. So that's our next step, is fully immunocompetent mouse model, and then kind of go from there.
And a preview of what I'll say this afternoon. It's actually our fault, the people in the clinic, that you don't know exactly which models represent the human disease. So I blame myself for that.
How could you do this to us?
All right, with that, we're on time. I'd like to thank all our panelists, and thank you all for your attention and participation.
Thank you very much for the panel. We're going to come back at 2:25, and we're going to get an update on clinical trials.